Hi. Today we shall discuss when do we institute pacing and what are the modes that are usually preferred. We shall use some cases to discuss this, and the objective is essentially review the evidence of pacing requirements in patients, what choice of device, why is it important to figure out symptom and rhythm correlation, and what are the challenges in decision making for patients. So let's take this 15-year-old student undergoing a pre-athletic checkup, presenting for an opinion, with having a physical examination that is fairly normal except for a soft S1. The echo is normal. This is the ECG. As you can clearly see, you have a P wave followed by a wide PR interval followed by a QRS. Fairly, the QRS appears narrow. V1 to V6, the transition is fine. The PR seems to be fairly consistent. Now, this is first degree AV block, right? With the long PR interval, P is associated with the QRS. The QRS is fairly narrow. But what is important is to understand this patient is a young person, it's a pre-athletic checkup, and you want to figure out if or not this patient has a requirement for pacing. So, next step is obviously the treadmill test to see if the PR interval shortens. If the PR interval is able to shorten, then it's a functional hypervagotonia induced PR interval prolongation. Another clue is the fact that there is the presence of a slow sinus rate also. Why I say sinus is because lead 1 and lead AVF are positive in their P waves. Lead V1 is positive negative and lead V2 is also positive. So sinus exit, slow sinus rates, prolonged PR interval, young patient, normal heart, likely to be hypervagotonia induced, slow heart rate and therefore prolonged PR. If the PR remains constant despite the high exercise capacity, then if the patient is asymptomatic, one may not do anything. But if the PR remains constant with a low exercise capacity, or there is drop of a P wave in being conducted to the ventricle, then perhaps this patient needs a pacemaker. Normal expectation is that the treadmill test will shrink the PR interval back to normal physiological levels and one may not have requirement for a pacemaker. Now, if you have a 45-year-old male presenting with complaints of skipped beats, presenting for an opinion with a normal physical examination, normal echo, but the ECG shows this pattern, what is to be done? Now, on kind of close look, the first thing is there is ST elevation on the ECG. There is probably an inferior wall myocardial infarction going on, which is worrisome, requires immediate shift to the cath lab. Probably the patient is diabetic, as a result of which he hasn't been able to feel the chest pain associated with the myocardial infarction. What is important is, however, that there is some kind of a associated arrhythmia that seems to be going on. If you look in slightly more details about the arrhythmia itself, look at how the PR interval for each P wave is slightly prolonging until the P wave drops. And if you look at the ECG rhythm strip, there is grouped beating that you can see. This is indicative of what is called as a type 2 AV block, but Mobitz type 1 Wenckebach sequence. Here, the site of the block is actually the AV node itself, and it is not the infra AV nodal location for the AV block. This is a fairly benign arrhythmia, commonly seen in patients with high vagal tone or in patients with inferior wall MI, and as such does not require any pacing support unless the patient is hemodynamically unstable. In this patient, definitely referral to the cath lab for an urgent PTCA and possible stenting is critical. The classical Wenckebach type 1 second degree AV block shows a progressive lengthening of the PR interval until a P wave is blocked. There is a progressive shortening of the RR interval until a P wave is blocked, and the RR interval containing the blocked P wave is shorter than the sum of two PP intervals. So, is a pacemaker needed? Definitely not. Here, the patient needs to be referred for a PTCA. Now, let's go to case number 3, where we have a 58-year-old female, known case of diabetes and hypertension, obese, status post anterior wall MI 6 months ago, non-revascularized, presents for complaints of skipped beats. Physical examination is normal. Echo has an ejection fraction of 45% with regional wall motion abnormality in territory of the left anterior descending artery. Now take a look at this ECG. Here the QRS is narrow. Again, you can see grouped beatings which are seen from the previous ECG, from just like the previous ECG. But where you see the pause there, you can actually see that there seems to be a sudden loss of conduction. And this sudden loss of conduction is worrisome. That is what we are kind of trying to figure out, whether there is some abnormality that requires pacing. Here again, let's see the P waves. The P waves seem to be probably sinus. Lead 1 is positive. Lead AVF is also positive. Okay. Lead 2 is positive negative. Lead V2 is again positive, suggesting as a sinus exit. But on further close examination, one can actually see that there is slight variation in the P wave, namely the one just before there is block of the P wave come conducting to the ventricle. So this is one P wave, this is another P wave, this is another P wave, and this P wave gets blocked. Now the question is whether pacing is required. There is persistence of the ST elevation here, suggesting that perhaps the ejection fraction is low because of an aneurysm. Evaluation of the palpitations of the skip beats suggests that this may be correlating, the sinus pause may be correlating to the feeling of missed beats, and perhaps this is similar or suggestive of a type 2 AV block, namely a Mobitz type 2, where the block in the conduction may be infra AV node. This further is importantly noted that the PR interval for the beats that are conducted doesn't really show prolongation of the PR interval, showing that the block is not at the level of the PR interval, but in fact below the level of block is not at the level of the AV node, but in fact below the level of the AV node. So here what we know is it's an old MI, ejection fraction 40%. The P waves are slightly varying just before the P wave drops. The site of block is not the AV node, it's the infra AV nodal location where the AV node has been blocked. The physiology is probably suggestive of a Mobitz type 2 AV nodal block. And here, when we are worried about pacing, it will actually depend on whether or not there is a syncope, in my opinion. Here we may say a pacemaker is required if the patient keeps having episodes of symptoms, but this could be a blocked PAC and perhaps requires a EP study to document the location of these PACs and to make sure that they are not originating from the sinus node. In the absence of ability to do an EP study, one may be probably better off using a pacemaker here, and given that the expectation for the pacing in the ventricle is less than 40% in this patient, it may be valuable for us to just give a dual chamber pacemaker and not require a CRT. Proceeding from here to this case where a 72-year-old male who's a known case of hypertension presenting for opinion with complaints of fatigue, who on physical examination shows Canon A waves, whose ejection fraction is 60% with left ventricular hypertrophy, shows this ECG where it doesn't seem as if the P wave is conducting to the QRS despite the P wave being fairly normal, namely positive in 1, positive in AVF, lead V2 is positive, lead V1 is positive negative, suggesting a sinus node exit of this P wave, probably biatrial enlargement, and the QRS that is there seems to not be associated with every P wave seems not be associated with every P wave. There is more than 3 P waves that are not conducted, suggesting that there is a high degree of AV block, probably at the level below the AV node, with the escape which may or may not be from the fascicle or the His bundle, suggesting a high grade AV block in this patient, wherein there is requirement for pacing. By definition, at least 2 consecutive sinus P waves need to be blocked. It can either be a Mobitz type 2 or a complete AV block. Independent P waves and QRS complexes, when they are present, not in this ECG however, but if on prolonged monitoring we find that is probably suggestive of a complete AV block with independent P waves and QRS complexes. The ventricular rate as seen in this ECG is lower than the atrial rate. The ventricular activation is maintained either by a junctional escape, namely a narrow QRS, or a ventricular escape, that is a wide QRS. Here the QRS is wide and probably is a ventricular escape. The mere presence of a wide ventricular escape does not really say that the block is within the AV node or below the AV node, but the presence of a narrow ventricular escape definitely suggests that the block is within the AV node. Pacemaker is definitely needed in this patient, even if the patient is asymptomatic. Now, here we have an 84-year-old female, known case of atrial fibrillation and senile aortic stenosis, who underwent percutaneous replacement of the aortic valve, presenting with new onset shortness of breath 1 day post procedure. The physical examination shows regular pulses, bradycardia, and an apex pulse deficit of less than 10, with a screening echo showing an ejection fraction of 60%, normal LV, slow heart rate, and normally functioning aortic valve, whose ECG shows atrial fibrillation with a regular RR interval with a narrow complex QRS, suggesting that this is atrial fibrillation with AV block. Why AV block? Because the sine qua non of atrial fibrillation, that is the irregularity, is no longer present, and the QRS is narrow, suggesting that the block is at the level of the AV node. In patients who undergo aortic valve replacement, the positioning of the aortic valve frequently damages the frequency damages the AV node itself, and as such, this is what one expects. What is critical is to understand that this patient has underlying aortic AV nodal disease because of the valve, and as such should not be left to be discharged this way. This is atrial fibrillation with a slow, regular ventricular rate suggestive of AV nodal disease in the presence of atrial fibrillation, definitely needing a pacemaker. Now, the same patient presenting with shortness of breath 1 day post procedure and this ECG. On closer look, you can see that there seems to be a wider QRS here. There doesn't seem to be association of the sinus P wave with that of the QRS. There are more QRSs than sinus P waves here, and there seems to be a slight variation in the RR interval, which is not explained by any APC. Here, this is actually a first degree AV block with blocked PACs. You can actually, on closer inspection, look at a block within the T wave. You can see that this T wave is sharper than the others. So just prior to the sinus pause, there are blocked APCs which are causing the sinus pause. This is a physiological phenomenon, and unlike the previous case, does not require any kind of pacing. We need to observe this patient mainly because the conducted QRS is wide, and we want to see if there is further worsening over a period of time. Now let's go to the next case, where we have a 62-year-old female, hypertensive, on amlodipine and beta blocker, presenting with new onset shortness of breath for a day. showing a low, regular, slow rhythm with Canon A waves on JVP, who is having an ejection fraction of 60% with a normal LV and slow heart rate, whose ECG here shows block every alternate beat of the sinus P wave, wherein we look at the conducted QRS being left bundloid in nature, but the P wave is actually blocking at every alternate beat. This is a type 2 AV block, Mobitz type 2, and if you look at the RR interval, may have ventriculophasic phenomenon where the PP interval is shorter when it comes to the conducted QRS and the PP interval is wider when there is no QRS that is present. So this is the shorter PP interval, whereas this is the longer PP interval. Here, definitely I do think a pacemaker is needed, given that the patient has a wide QRS and the conducted QRS, conducted PR interval, the PR interval for the conducted beat is relatively narrow or normal, suggesting that the block is below the level of the AV node, thereby requiring further pacing support eventually. Going to the next case, where a 68-year-old male who is a known case of SVT on beta blocker presents with fatigue. Physical examination shows a slow, regular rhythm. Screening echo is ejection fraction of 60% with a normal LV and a slow heart rate. But the ECG here actually shows sinus bradycardia, where the sinus P wave is actually seen in 1 and AVF, whereas in V1 you have a positive negative and V2 with a positive P wave suggesting a sinus nodal exit. This is sinus bradycardia. You know that the sinus bradycardia P wave is as I have described, and definitely a TMT should be used in patient to help decision making after stopping the beta blocker for 5 half-lives. Why the TMT is because the beta blocker here is not an essential drug, and as such there could still be chronotropic incompetence wherein the patient is more sensitive to beta blocker, and as such, and so you want to diagnose the presence of the chronotropic incompetence before you advise the pacemaker. It seems here in this case that the beta blocker may have exacerbated the pre-existing chronotropic incompetence and causing significant sinus bradycardia. Let's go to the next case, where we have a 45-year-old female, known case of ASD, post-cardiac surgery for correction of the same, physical examination showing a slow regular rhythm, screening echo with an ejection fraction of 60%, a normal LV and a slow heart rate, whose ECG here, as you can see, shows a sinus P wave, where it is positive in lead 1 and lead AVF, lead V2 is also positive, narrow QRS across the board, a fixed PR interval, and a gap in the RR interval, which seems to not have a sinus beat or a P in wave in between, seeming to suggest a sinus pause. Now, if you look at the width of that pause is double the sinus PP interval, suggesting that this is sinoatrial exit block, wherein the sinus node is firing but unable to exit into the atrium, perhaps because of scar from the prior surgery, and as such it manifests as a dropped P wave, distinguishing it from a blocked PAC, where you will see a separate P wave that is present. Is a pacemaker needed here? It is unlikely. You will need a Holter to aid with management as such, and also probably require a TMT to see for chronotropic incompetence. Finally, we have a patient who is a 45-year-old female, known case of Sjogren's disease with repeated episodes of syncope, presenting for review of the Holter report, whose physical examination is normal. Screening echo has an ejection fraction of 60% with normal LV function and a slow heart rate, whose ECG, as you can see here, shows a fast heart rate followed by a gradual slow heart rate. Here again the P wave is positive in 1 and lead 3, surrogate for AVF, suggesting a sinus nodal exit for the P wave, fixed PR, a narrow complex QRS, and 1:1 P to QRS association, who now suddenly presents with a dropped or absence of a P wave at all, and a sinus pause with an escape rate or escape beat which is similar to the conducted QRS, terminating the sinus pause, but no P wave seen. This is where there is sinus arrest that we can see, and here probably you will still need a pacemaker. Before the pacemaker, however, is advised, there is need to see the time of the day of this episode on Holter, because this can happen if the patient has had obstructive sleep apnea, and as such, the snoring can lead to these kind of episodes. If it is at the time of the night, if it is a Holter, the time of the episode will actually tell us whether a pacer is needed or not. If it is in the night, looking at sleep apnea and treating it might actually be of value, but if it is during the day, further evaluation may actually be needed to see why these episodes are present. 24-hour blood pressure monitor, especially in a patient of syncope, if actually showing a low systolic blood pressure and a tendency for daytime blood pressure drops, can actually look at the reason for the syncope. Also, there is the presence of a pulse pressure, 24-hour pulse pressure. If less than 32 millimeters of mercury in the 24-hour blood pressure monitor, shows the highest predictive ability for reflex syncope. And as such, in our armamentarium for syncope, this is something that is needed to actually help us understand if reflex syncope can be present. These are the drugs, namely, which are at high risk of causing reflex syncope because of postural hypotension. It is namely the sympathetic central sympathetic blockers that are at this level, namely clonidine, doxorubicin, reserpine. The ARBs and the lisinoprils are unlikely to cause this. Loop recorders remain a very important investigation in our armamentarium for these patients, and gender and syncope remain the only reasons where outcomes of the ILR based monitoring of the patient can be influenced. It can help us once all routine tests are done to help you with change in management, namely to say whether it is a non-arrhythmic cause of syncope or it's a pacemaker cause of syncope. This remains very important in aiding us in making clinical decision making. In patients with syncope, there is significant value in implanting a ILR, especially if other investigations are done. In patients with palpitations, atrial fibrillation is commonly diagnosed, which can then help us evaluate whether the patient needs anticoagulation or not. For the ILR, the number needed for change in management is the highest when we come across for palpitations, but in patients with syncope, you require, it has got a good efficacy too. The Sprightly trial is a trial wherein we had a patient with bifascicular block undergoing a trial of pacemaker versus that of a implantable cardiac monitor. It was noted that patients who had a pacemaker did actually much better in terms of the composite outcomes of syncope, bradycardia causing crossover or cardiovascular death as compared to the ILR based monitoring group. This was true for patients above the age of 50. So if you have patients with a bifascicular block above the age of 50, undiagnosed syncope, perhaps implanting the pacer will help prevent mortality outcomes, whereas it may not decrease the syncope as such, suggesting that the syncope in this group may actually be multifactorial as compared to unifactorial. There were also studies wherein patients were taken for EP study prior to implanting a device in the absence of structural heart disease, but it was noted that the EP study did not actually confer any benefit in these patients. In patients with Brugada having syncope, the loop recorder still showed that it was mainly reflex syncope, and arrhythmic syncope was present in only 8.6% of patients. As such, when you characterize the syncope, the reflex syncope remained a very important cause, and as such, the tilt table would be a very valuable test to do in these patients. Outpatient implantation of the insertable cardiac monitor is straightforward and barely takes about 10 minutes for the patient to go in and out. With relatively cheaper ILRs in the market today, use of the ILR to help patient diagnosis is becoming of increasing importance. In summary, therefore, before we implant pacemaker, correlating the symptom to the rhythm abnormality is critical. Sinus node dysfunction cannot be diagnosed on a static evaluating mechanism. It requires activity and documentation of the sinus node dysfunction during activity that will decide whether the patient needs a pacemaker. The rate response is critical for sinus node management. Symptomatic second degree AV block is an indication for pacing. Asymptomatic AV block more than a Mobitz type 1 requires pacing. Temporary pacing is life-saving. Gray area still remains as syncope in patients with bifascicular or trifascicular block, but going by the sprightly trial, it seems that patients greater than the age of 50 with bifascicular block seem to do better with upfront implantation of the pacemaker. As for the mortality outcomes, but syncopal outcomes will still require evaluation and further management. In patients with Brugada having a syncope, reflex syncope still remains a very important reason for the syncope rather than an arrhythmic cause. Implantation of ILR gives you value in being able to diagnose reasons, especially when all other tests have been completed, and the maximum value for changing the management remains in patients having syncope and in patients with palpitations. Thank you for your patient listening. Please do send us your questions if they are present.